my witnesses. Welcome to the Swog Radiation Oncology Research Support Meeting. This is the Radiation Oncology Research Support Committee. We have a great agenda. I'm here to welcome you. Thanks for all that you do on behalf of our patients and for Swog. And I'm going to hand it over to Dr. Lisa Kachnik for her executive summary of what's going on at Swog. After that will be Sanjay Aneja, who's going to give the keynote on some really cool stuff on machine learning and implications for imaging and clinical trials. That'll be followed up by some really cool studies that were reported, not reported, but presented, study concepts to us over the last couple of months that are really just neat translational science. And then that'll be followed by some disease liaison reports about what's going on in Swog. So this is going to be a jam-packed 2 hours, followed by a little bit of a discussion. So without further ado, Dr. Kachnik.
Thank you. Hey everyone, welcome. I hope next time we'll at least have a hybrid meeting. Next slide. Oh, well, great. Don't forget.
Oh, Plenary. These are mine. Yeah, sorry.
I can go. You be careful and do your contours. So yeah, actually I'm on this panel and I'm pretty psyched about it. So our Plenary 2 is going to be a little bit different this year. Instead of hearing science either from Swog or external, it'll be a panel with one of our own, Dr. Reshma Jagzi, as the keynote, and it's all about integrity and ethical behavior in cancer research. So please join us for that. It's Thursday from 1 to 2:30, which could be Central Time. So just check that part out. Next slide. So I think you've heard the agenda. So we'll go right into my executive summary. Next slide. Oh, but we want to grow. See, Dr. Yu, I'm taking all your thunder on your slides. So we have a couple of asks, which will be in my slides coming up. But we have a great cadre of committee members, but can always have some more as, again, our world has turned more virtual, and I think we'll be hybrid moving forward. We also can now generate a trial of our own if it's not on the high priority list for one of our disease site groups, although you need buy-in from them. And I'll talk about that a little more in a second. And our monthly meetings are typically the last Tuesday of every month. Thank you to everyone who's participating today, either as a speaker or as an audience member who can always, we are a bit of a non-formal committee in that we take questions as we go on. So please chat your questions. Next slide. All right, so now here are my slides. For anyone that's new joining us today, I'm one of Swog's, I think we could even be up to 7 or 8 now, executive officers. We each serve a different role, and my role is to really be the liaison between the sort of non-disease site multimodality group. So it includes us, surgery, and imaging, so that you're informed of kind of what's going on at Swog, but also to make sure, for instance, if I had a GI trial, that I get traction at the GI committee with it, and to also go over funding opportunities, etc. Next slide. So I mentioned about new concepts. So you'll hear many today. I think they're all sort of sitting in the disease sites. But like I said, if there's an instance where you're just not getting enough priority at that site, we can consider running it through our committee. What we've been doing more of, but there's so much data, we could do it even more, are looking at our past trials to ask questions that may inform a new trial moving forward. So doing a secondary endpoint analysis. Oh, I'm sorry, I skipped. I'm combining two things. What I'm talking about is secondary analysis, so we can do that. But a lot of us have been co-investigators more from a radiation aspect for secondary endpoints on studies. Sometimes they're QA related, but they could be sort of imaging or other things as well. And then there's always travel grants for when we do go back live for newer junior members. So you have to kind of always be looking at the website, but I try to bring those opportunities to you during our monthly meetings. And I'm going to review the next cycle of Hope Foundation grants on the next slide. Next slide. So here's our upcoming ones. So the first one is the SWOG Early Exploration and Development Seed Fund, and that application's due December 1st. This awards $50K for preliminary research that could translate or inform future clinical trials within SWOG and then the NCTN groups. To the right are the Encore pilot grants, and to remind everybody, these are the NCI Community Oncology Research Program sites. In fact, Columbia is a minority-based, and when I was in Boston, I also had a minority-based one. What Encore does are symptom management, survivorship, palliative care at SWOG, prevention studies, cancer control studies, and then cancer care delivery in the community studies. So any sort of ideas for that, and this is, I have to say, I don't remember ever seeing this before, so this must be new. These are also due December 1st. And honestly, these $50K awards are not onerous in terms of the application. And although I think in the past couple of review cycles, the N has gone up, it's still, you have an excellent chance. I would say there's usually like somewhere between 7 and 10. So that's not bad for your chance to get it. Right below that is a larger grant opportunity. That's the SWOG Hope Foundation Impact Award. Actually, several of you participating today have been awardees of this. So congratulations on the past and current ones. And the letter of intent for this is due in mid-January, and you actually get up to $250K. These are also, I would say this one, it could be a lot of different things. It could be to fund almost your role in doing an interesting study within SWOG if you have the support of your group. But it also can be sort of more out of the box research that would inform a new concept. And then to the left is the Dr. Charles Coltman Jr. Fellowship. Dr. Coltman actually was the group chair when I first got involved in SWOG a long time ago now. And these are 2-year fellowships of $50K per year for salary support. And this is to give protected time to actually do research, which could be laboratory or clinical, again, trying to inform a potential new study. We have had members of our committee that have also been awarded this. So please give that a look too. And that letter of intent's also due mid-January. Next slide. So I know Dr. Thomas, if he's on, you gave us a potential person, but I'm putting it out again because we should probably formalize this and collect CVs. We need a physics representative on our group. It could even be someone from the Rhode Island IROC, so we can consider that too. To participate on, we have a physics committee for the NCTN, and somehow I myself am our representative, and they really don't need me. My expertise for them is limited, although sometimes I am a little helpful, especially if it's more clinically physics related. There's opportunities for this for wider consensus papers. They meet monthly, I know, because I'm on it for about an hour. And if you can submit from your group's potential CVs, we'll look and choose. And also, if we have folks from IROC, Rhode Island, we're happy. We could have 2 people. We're happy for you to be one of our representatives too. Next slide. Now we have an opportunity, although I think we might have asked one of ours to at least serve in this role today, for an MD liaison to our Encore site. I think Dr. Conley we've nominated Dr. Conley for today to give an update for the committees that she's on within SWOG's community Encore group. But there are several committees, so it's possible we could have more than one liaison. For liaisons, we've never, we've had this for so long, we probably never had a formal job description in SWOG, although we do at NRG. And just to give you my thoughts, you provide input to multiple committees, notably as it relates to RadOnc expertise. I think you would participate here at the Encore or for whatever disease site you are in 80% of their calls, as well as the semi-annual meetings, but you always have to come to RadOnc. For this, report to us back on Encore activities and concepts that might be relevant to radiation oncology. Hopefully solicit and develop concepts and protocols yourself, as well as secondary analyses. Serve as a concept reviewer for Encore as needed. And then to me, it's all about identifying cross-committee opportunities. And you're really the sort of fulcrum of communication between our committees. Next slide. I did want to mention, I don't know if folks notice this on Twitter or on Dr. Blanky's emails where he provides. I have to say they're really good when he gives the SWOG letter updates, which I feel is more than once a month, but maybe it's only once a month. But this has been gaining a lot of attention, and this is Joe Unger, who's a very senior statistician from Seattle that's been a part of SWOG for a really long time. And he's just done a ton of great papers that show the power of our clinical trials. And this one was another one. And he showed that NCI-sponsored trials, so not just SWOG, has added 14 million years of life for cancer patients. So this paper included 163 phase 3 trials from 1980 through 2019 that reported statistically significant findings in favor of the experimental treatment for at least one clinical time-dependent outcome. So he and his co-authors estimated that life year gains from 128 trials that found either statistically improved overall survival or a trend to improved overall survival, and then map these gains onto the US population, which gave them the analysis that through 2020, these results gave an additional 14 million years of life to people with cancer in the US. And the authors project that by 2030, 23.4 million life years will have been gained based on the same set of trials. So even though I believe these trials were more than just SWOG, but I could be mistaken since it's from 1980, I know the group chairs from the other cooperative groups are trying to make sure that we can expand this for many other trials. So potentially maybe this was just SWOG. And this was just presented and got a lot of traction at ESMO a few weeks ago. Next slide. I think that might be it. Yeah. So does anyone have any questions for me? All right, I'm not seeing any in the chat. So I think if I can recall the agenda, we have our keynote speaker next. Yes, I just would love to welcome Dr. Neha, who's assistant professor at Yale and going to talk to us today about machine learning and quantitative imaging for clinical trials. Thank you so much for agreeing to present your work to us today.
Perfect. Thanks so much. Yes, so thanks a lot, everyone, for the opportunity to speak at SWOG. Today, I'll be talking a little bit about machine learning, quantitative imaging, potentially opportunities that our lab feels like there are for quantitative imaging in the context of clinical trials, and then hopefully provide a nice broad overview that will stimulate a little bit of discussion. Next slide. So these are my disclosures. Next slide. So our lab is primarily focused on the areas of machine learning, and we have a very multidisciplinary group of data scientists, clinicians, computer scientists, and engineers who help us in those efforts. We actually are very data stream agnostic, which means that we're interested in evaluating a variety of different kind of healthcare data streams. A lot of the work that we do is primarily in imaging, and the reason for that is just because imaging is an area in which machine learning has shown some rapid advances recently in the areas of computer vision. Also, because of as a clinical radiation oncologist who primarily treats a CNS and a little bit of prostate, imaging is something that's kind of close to us in our clinical workhouse, in our clinical wheelhouse. Next slide. So today, first I'll kind of provide a little bit of a vernacular, just trying to give good vocabulary to everyone about artificial intelligence, machine learning, and quantitative imaging. I'll briefly touch about non-imaging AI and ML applications, specifically in the context of clinical trials, which I think is good just to provide us, not to be completely focused on imaging. And then we'll talk a little bit about quantitative imaging. And then lastly, I'll talk a bit about quantitative imaging in the context of clinical trials and ways in which we feel like clinical trial data can be used for quantitative image analysis. Next slide. So first and foremost, how do artificial intelligence, machine learning, and deep learning differ? Those are words that are kind of oftentimes used synonymously. It's interesting. I've had this slide for almost 3 years, and I usually basically begin all my talks like this, but this is maybe the first meeting where I thought maybe I could take it out, partly because I think that ML and AI has become so pervasive in radiation oncology that most radiation oncologists don't find these terms to be nearly as scary as they did 3-4 years ago. Nevertheless, I decided to include it just to make sure that we're kind of all on the same page. So next slide. So the way I like to explain and the way I'd like to keep track of kind of all three of these is I first think about one, the role of the user, and second, the role of the data. And so AI is broadly defined as any program that mimics human intelligence, and intelligence is really a broad form of that. It's sort of any sort of human behavior. The role of the user in all AI applications is just basically define those rules that determine the algorithm. And the data is just actually used to provide a test for the algorithm. And so the most basic form of artificial intelligence is probably like IBM Deep Blue, which is the chess playing supercomputer from the 1990s. And all of the programming for that was actually manually programmed. All of the rules that were determined for the chess game were actually manually programmed by the computer scientists at IBM. Next slide. Now, machine learning is a little bit different. It's kind of the newer variant of IBM Blue. And so it's kind of like the IBM Watson is sort of the machine learning product from IBM now. And in machine learning, the rules of the algorithm are actually defined by the data. And the user's role is really a little bit more separated from, instead of actually programming all of the individual rules of the algorithm, what they're doing is they're actually programming the features that are the most important. And then the computer kind of determines which are the rules that are the most important. And so the things that you kind of sometimes hear for these are like random forest models, support vector machines, k-nearest neighbors. Those are kind of common machine learning algorithms. And then the last one, next slide, is deep learning. And so deep learning is very hot, obviously. It's a specific type of machine learning, which has some unique properties, which really makes it sort of a separate kind of discipline in itself. And so in this area, what we find is these are kind of what you think about now when you're seeing like Alexa, Siri, virtual assistants, and things of that nature. And the way this works is that the user really doesn't define anything. The user just provides 100% raw data. And the algorithm structure, as well as the rules in which the algorithm kind of makes decisions, are basically defined by the deep learning algorithm. Deep learning architectures are fundamentally based off of what we call neural networks. I'm not going to get into too much detail about that just because of the interest of time, but it's an area that we do a lot of research in, and so we'll show some of the work that we've done in that. Next slide. So the focus of today's talk is quantitative diagnostic imaging, but I would feel remiss if I didn't touch upon the non-imaging ways in which ML and AI is finding its way into clinical trials. And so I'll touch on those next. Next slide. I find that there's probably like 3 areas in which I would argue that I see machine learning and artificial intelligence sort of creeping its way practically into clinical trials. The first is in the electronic health record. The second is in actually digital pathology, which is something that's rising rapidly. And the third is actually in drug discovery, which is something that a lot of our basic science colleagues are very interested in kind of in sort of gaining traction on. Next slide. So the electronic health record, I can tell you that our group does a little bit of work in this area. We're just starting, but a lot of our work is in imaging. I kind of highlighted 2 examples of that. One is from the group at UCSF, Julian Hong. They did a machine learning algorithm that's specific to radiation therapy that kind of identified which patients would need intensive monitoring during radiation treatments to prevent hospitalizations. The other algorithms that I'm kind of more well aware of that's pretty well developed is the ones from the group at Penn, Dr. Ravi Parikh, who's a medical oncologist, and they've used machine learning algorithms from the EHR data to predict patients who have 180-day mortality at high risk. And so then they've, in essence, tried to prompt goals of care discussions using that as a trigger. Next slide. So for quantitative pathology, this is an area that our lab doesn't do anything in, but I thought it would be helpful to just kind of provide one study that I thought was quite good. This is a study that was done by the group, I guess they were at MSK, but now Thomas Fuchs has now left to go to Mount Sinai. But essentially, they've found a way to do clinical grading on automatic pathology slides. Believe it or not, the mathematics between that and what we do on diagnostic imaging is pretty much the same because they're still similar pictures. There's a little bit of differences in pre-processing, but really it is actually very similar. And so what they found was that they had an ability to detect cancer that was clinically significant and also detecting the presence or the risk of lymph node metastases in breast cancer patients. Next slide. So drug discovery is actually an area that can be a talk in itself. And I think there's a lot of groups that are very interested in many aspects of it. I think the most important thing to get from this review article that I've kind of pointed here is that there's so many points in the drug discovery pipeline in which machine learning is becoming more used. I think the primary areas, at least that in talking to my friends in our chemistry department here at Yale, who do some of this machine learning, is in specifically identifying targets, so drug targets and predicting affinity. And then also, I think that on the clinical side, there are a lot of people who are interested in trying to predict either pharmacokinetics or adverse events off of similarities between chemical structures between drugs and other drugs, and seeing whether or not there's a correlation between a high risk of having a side effect or not. But I would tell everyone to read this review article. It's really good. It talks about all the different points of a drug development pathway in which AI could potentially be helpful. Next slide. All right, now we'll go into the crux of what our lab actually does, which is quantitative imaging. First, I'll talk a little bit about quantitative imaging in the kind of the ways in which people kind of think about it, at least the way that our lab likes to think about it. And then we'll talk a little bit about 3 specific scenarios in which our lab has done work looking at ways in which we can integrate quantitative imaging on potentially clinical trial data. So there's kind of 2 forms, I think, prevailing forms of quantitative imaging that are done right now in diagnostic imaging. The most kind of tried and true way, I would say the way that it has been around for slightly longer, is radiomics, which is sort of feature extracted from diagnostic imaging. The other is deep learning based, which is essentially using raw pixel data to develop your own features. So that's the deep learning side of the machine learning coin. Now, I'm not to say that these are completely distinctly separate. I think you can actually do both, and I'll show an example of a paper where they do deep learning and radiomics together. But oftentimes, I think that those are it's confusing to people whether or not someone's doing deep learning or whether or not they're doing radiomics. So next slide. With radiomics, we're basically taking quantitative metrics extracted from medical imaging using high throughput computational techniques. They really focus on 3 domain areas: shape, texture, and intensity. And they developed this very high dimensional form of data in which one can basically analyze an image and get more robust features than potentially could be seen by the naked eye. Now, once people get those radiomic features, which can be very large in scale, then the question is whether or not you actually do further machine learning, or if you can just do regular sorts of Kaplan-Meier curves or correlative analysis using traditional statistical techniques. Next slide. So this is just a schematic that was actually published in the JCO-CCI a number of years back that looks at sort of how one would do a radiomics analysis. And the key piece is that they use the tumor, they segment the tumor, oftentimes using contours that are defined by a physician, whether it's a radiologist defining it or a radiation oncologist, is either or. And then they do the feature extraction, which is actually not extremely complicated, but it develops this high rich data. And then from there, there's actually, the possibility of doing dimensionality reduction. So you go from these large number of radiomic features to maybe the 30 most important features based off of a dimensionality reduction algorithm, and then you can use that to correlate outcomes. Next slide. So deep learning is a little bit different because instead of actually extracting defined features that are standardized across shape and texture and intensity, deep learning, the features are a little bit less known. They take raw pixel data and they extract features. And so what we'll see is this is an image of a bird and this is a classification algorithm. This is what we call a convolutional neural network. I'm not going to go into too much detail about the mathematics of deep learning. If people are interested in that, I'm happy to talk about it afterwards. But the idea is that these features are actually a little bit less stable. And the reason for that is because they're not necessarily defined as strictly as radiomics. Many would argue, including myself, that there are radiomic features that are included in the features that are derived by deep learning architecture. But at the same time, it's a little bit more unstable and requires a little bit more of a careful eye when you're doing these sorts of studies. Next slide. A way to think about deep learning at 1,000 feet is that the pixels are basically zeros and ones. And then every layer of a neural network, we're defining a higher level of abstraction. So from the pixels, we determine lines, which is essentially done with edge detection. From lines, we develop shapes. From shapes, we may develop facial features, for example, and then we put that all together for faces. And so the idea is that those last layers of the network, those last feature layers of facial features, they're really your core features that are determining your outcome. And so an example maybe in cancer would be that pixels go to lines, line goes to shapes, and shapes go to imaging correlates, which are very important, like spiculation or enhancement or tumor size or, lymphovascular invasion, things of that nature. And those would be kind of correlated with someone's outcome. Next slide. So I think a lot of people like to think that the quantitative imaging folks, like the radiomics folks and the deep learning folks, are kind of rivals against one another. I would argue that our lab is probably a little bit more focused on deep learning because we come from an applied mathematics background. But I think that really we've used both of them in analyses. Deep learning has advantages and radiomics has advantages. I think deep learning's advantage is that there's no bias in the feature selection. So there's not these set rigorous features about shape and features and textures that you have to adhere to. The other thing is mathematically, it can model any sort of function, which is nice. And domain expertise is a little bit less important. So if you don't know a lot about the tumor, a lot of deep learning architectures will just let you put in the raw pixel data. And that means that there's less burdensome pre-processing, whereas radiomics requires a significant amount of pre-processing. Now, the radiomics has its advantages because honestly, there's less data requirement because you're fitting into this kind of regimented, and not regimented, I guess, this sort of more thought out way of defining your features. You don't need as much data to sort of figure those out. On an engineering side, it's less computationally intensive. You could probably do a radiomic study on a regular PC computer, whereas deep learning, it's difficult to do it on a PC. You really need like GPU-based servers or a very high performance computer. I think the stability of radiomics is a lot better than deep learning. Deep learning models can be tricked in various different ways to give outcomes that we don't expect. And I think that the last is that there's relative interpretability. So a lot of the people who are interested in doing basic science correlates to quantitative imaging like radiomics because we can see that shape features are more indicative of an outcome. And so then we sort of look at, well, okay, we see that shape and intensity are the two most dominating factors in someone's outcome. Maybe we can explore that more in the lab in some way, shape, or form. Next slide. So I think that they both have shown merit. So on the left, upper left, you can see that there's an argument to look at decision support for non-small cell lung cancer. This was published in Nature Communications using radiomic features. And so they used features to determine non-small cell lung cancer outcomes. We'll show some data in a little bit that shows that you can use deep learning for the same thing for early stage non-small cell lung cancer. On the right is a study that was done by our group that was in the JCO that looked at deep learning to identify extranodal extension for head and neck cancer. And so that shows the benefits of deep learning. And then kind of the synthesis of both of these was something that I just found like maybe a couple months ago, which is sort of a deep learning radiomic approach that looked at axillary lymph nodes. And so, the potential is that one, I think that both have merit. Clearly there's different imaging modalities, PET or CT or MRI imaging, and also a variety of different cancer types. So non-small cell lung cancer, head and neck cancer, and breast cancer. That's kind of the reason why this slide, I think, kind of encompasses a lot of opportunities in quantitative imaging. Next slide. So the next part is I'll talk a little bit about quantitative imaging and clinical trial data, and specifically talking about 3 areas in which I was trying to think about what's the most useful for this group who are very interested in clinical trials and interested in maybe secondary analyses. And so these are the areas that I think quantitative imaging has a potential opportunity. And this is by no means exhaustive, but it's something that I think would be a potential opportunity. Next slide. So why does, first and foremost, why do we think that quantitative imaging on clinical trial data makes sense? And why is our lab very optimistic that that's kind of the future of where we should take quantitative imaging studies? Because right now they're really institutional or multi-institutional studies, but they're not really at the cooperative group level where we have so many institutions with a variety of different backgrounds and different doctors treating them. Next slide. So I think that there's 2 sides of this coin. One is I think the clinical trial data really helps us overcome a lot of the weaknesses that occur with quantitative imaging studies. One is that there's a heterogeneous patient population, which provides a lot of data points that will make our quantitative imaging more representative of the entire population. What we're finding right now, and there's a study published in JAMA very recently, maybe in the last 2 years, that found that almost all AI algorithms in medicine are trained at 3 different cities in the country. Almost all the data is used from 3 different cities, and that's like San Francisco and Boston. And that just represents, sort of the groups that are working on quantitative imaging, but it doesn't actually represent the entire spectrum of cancer patients. And so there's some feeling that, having a cooperative group or a clinical trial at a multi-center institution to be used, you could actually kind of address some of those issues. Secondly, we find that there's standardized treatments that are in clinical trials. And so that means that we'll have less externalities that could potentially affect the signal of the images in such a way that could probably cause the machine learning algorithm or the deep learning algorithm to sort of cause us to be less confident in their ability to be predictive and safe. The third is actually image and treatment QA. So because we have kind of set regiments on how we should do imaging and how often we do it, and there's kind of metrics for that, there's a lot of the issues that you have with poor quality images that sometimes happen when you look at studies from way back. Those will be answered in a clinical trial context. Now, why do I think diagnostic imaging is particularly, oh, wait, go back, sorry. Why do I think diagnostic imaging is the reason? Well, for one is I think that the methodologies, as I've kind of showed before, are very, very ready for it, ready for clinical trials. Secondly, I think that unlike the EHR or secondary analysis that are looking at clinical variables, we already have a common data model, and we already have all of them in Rhode Island and IROC. And I've had a chance to go down there and visit with Dr. Fitzgerald and his team, and it seems like it's extremely well organized. And the last and most important from what I've been talking to my translational colleagues is it's a reusable data source. And so we don't have to really fight over samples and tissue and other things of that nature. And so I think that there's a lot of opportunity imaging. And I don't think that we're behind. If you look on the right, there are already European organizations that are already talking about integrating radiomics and quantitative imaging into clinical trials and publish consensus statements about how to do that. And so I think that we were probably not, I think that this is something that's going to be happening in the future. Next slide. So the 3 ways in which I think that quantitative imaging can be involved in clinical trials. First is something that we do a lot of work in, and that's probably what our group is most interested in, is imaging-based biomarkers that can be used to potentially fuel future clinical trials and kind of target our interventions for future studies. The second is actually an automated outcome capture, and that's actually something that the radiology group, the imaging group here, led by Dr. Schwartz, is doing, and they have a UL1 in it, looking at the RECIST criteria using the lung map data. And then the last is actually in secondary analyses, which is just an idea that we had, which was actually, speaking of the Coltman Foundation, was a Coltman application that we submitted. It was funded, but unfortunately, just because of some administrative salary support issues, we weren't able to take it for more than a year. But it is an example of a secondary analysis that can be done with quantitative imaging using existing clinical trial data. Next slide. So I think we know that there's problems with biomarkers. They're inaccurate, expensive, and invasive. And so the question is, can we use imaging-based biomarkers which harness the data of routine clinical practice, harness data that's already generated in routine clinical practice to better identify high-risk patients who can be further targeted in clinical studies, or potentially changing in sort of our way in which we manage those patients. And so I'll show the work that we've done in early-stage non-small cell lung cancer. Next slide. So we developed a deep learning algorithm that actually used dosimetric data as well as imaging data to predict treatment failure for early stage non-small cell lung cancer for patients who underwent SBRT. And so what we found was that if we combined our deep learning algorithm using imaging and dosimetry data, we were better at predicting that patients with the worst outcomes compared to just using a simple Cox regression, or just using imaging correlates alone, or just using like DVH endpoints alone. I won't go into the details of this network architecture, but it's a multimodal network that handles each data stream individually. Happy to go through it again if we have time at the end. Next slide. Just for people who are interested in clinical trials, so when we identify the patients in the algorithm who are predicted to have a failure within 5 years, and we find the ones that are not predicted to have a failure within 5 years, and we actually do a Kaplan-Meier analysis of them, we see a huge separation. And so the argument that our group would make would be that using this sort of imaging biomarker that we've developed using deep learning, we could potentially target those patients in the red line for future interventions, potentially a trial involving systemic therapy with SBRT, or maybe dose escalation for SBRT, things of that nature. Next slide. This is a slide that just kind of highlights when a deep learning algorithm is evaluating an image, it has to find the pixels that are the most important. And this is a way for us to check to make sure that the algorithm is actually looking at the right thing. So for example, if this was highlighting the patient's like left shoulder, then we know that the algorithm is just getting lucky and not actually looking at the tumor. And what we found here is that as we were sort of going down the network and the network was analyzing the image, it starts focusing on the tumor. And so that suggests to us that these are that the model is actually effective at analyzing where our tumor is. Next slide. So automated outcome capture. So we've done a little bit of work in this area, specifically in the context of brain mets. The first study I'll talk about is estimating the RECIST criteria in non-small cell lung cancer. This is actually done by the group at MSK. I thought it was very interesting because they used deep learning to estimate RECIST, and then they looked at the cohorts of the patients who were actually RECIST scored by people versus the people who were deep learning predicted based on their RECIST in an automated fashion. And what they found is that their outcomes were very similar, not exactly the same, but very similar. And so I don't think this is going to replace the way in which we analyze images, but I think that this could be a second check if there's discordance between potentially, a first reviewer and a second reviewer. I can tell you, I do image review for an NRG study, and it's like one of the most painful processes of my life, having to review so many MRI images over time. And it would be nice if I had an algorithm to tell me which ones are the ones I really need to like be focused on, and the other ones which are maybe less likely to have that. But less likely to have any differences. Next slide. So our group has looked at this in the context of brain metastases. Specifically, we have looked at the ability for us to predict, one, the presence of radiation necrosis on a follow-up image, and secondly, whether or not we could actually automate the estimation of a RANO brain metastases metric based on a radiologist. And what we found is that we were both able to identify radiation necrosis with a high sensitivity, as well as the ability for us to identify radiologist measured RANO brain metastases sort of metrics using deep learning off of the follow-up MRI. The network, I can kind of go into more detail, but it takes the input image from the pre-treatment scan as well as the output image. Second image is the first follow-up scan, and it combines them to provide a representation of your differences between the two pictures. Next slide. So the last piece that I'll talk about is secondary analysis. And so this is just an example of a secondary analysis that we were interested in doing using the lung map data. And I'll show you some of the prelim data that we did using our own institutional data. Because one thing that I think clinical trials represent is this huge amount of patients that have been treated from a variety of different institutions in a very, very dedicated way. And we should be able to learn from all of those patients. And so the question that we had is, well, if two patients, maybe their images look very similar based off of a deep learning algorithm, the computer thinks they look almost exactly the same. How similar are those outcomes? And can we really develop like a personalized treatment? Because very frequently when we look at clinical trials and we hope that they're randomized perfectly, we can't really control for tumor size because we try to, but sometimes, we find that, oh, well, if you actually look at the tumors, all these patients have central tumors and the other ones have peripheral tumors, and all these secondary analyses come out that kind of make us confused about what the ultimate outcome of the trial should be. And so what we did is we used a novel, I guess, a somewhat novel method of twinning patients using deep learning. And so what we found is that we had two examples. One is the digital twin. So it's the patient who's the most similar to the patient that we're interested in finding out their outcome. And then something that's called a digital family, which is like the 10 patients who are the most similar. And so we can tell a patient like, oh, well, based off of the 10 people who look just exactly like you on the inside, based off of your tumor, this is what we think your outcome is going to be. And we wanted to see whether or not that would be the same. They would have similar outcomes. And so we looked at this in the context of locally advanced non-small cell lung cancer. So next slide. this is sort of an example of the architecture. It's a little bit complicated, but what I'll explain is that the way you train this algorithm is you basically have to train it to move two pictures that have this, that are of the same outcome or similar pictures. So these two pictures of Barack Obama, you want to move those together. And what you want to do is separate the pictures that are different. And so the third picture is myself, and that's separated away. And so this uses a novel loss function called a contrastive loss function. It's a triplet loss. And so what we do is we train basically the algorithm to push all of the cancer patients, the non-small cell lung cancer patients who have similar outcomes together, and we have them separate the ones who have different outcomes. And then we still make it take that representation of the image into account. Next slide. And so what we found when we looked at the digital twins and the digital families, we looked at how different, what was the difference between the survival of a digital twin, between two twins, or the digital family and the patient of interest. And we also compared it to, like, if we just matched them based off of clinical cohorts, or if we matched them based off of a Cox proportional hazard model, or just off of their stage. And what we found was that the digital twins, the digital families appear to be the most likely to estimate survival compared to our staging systems and our metrics of Cox proportional hazard and matching, which tend to underestimate survival. And part of the reason I think that this is the case is because what we find is that actually, if we look at patients from way back and use them in our data set, the patients' tumors are tending to be smaller because of screening. And so now we're kind of accounting for that now a little bit with the digital families, because we're kind of like similarly making tumors who are of the same size sort of matched together. And so this is something that we're very interested in. It's an example of a clinical trial, secondary analysis that can be done with a clinical trial data set that would be very helpful. And the other thing that I think would be helpful is also for our ability to, if we're worried that a clinical trial maybe has some bias, we could use this digital twinning to see if there's actually twins among two different arms of a clinical trial. So for example, if we all, I know in radiation oncology, we always tell people that the SBRT arm versus the surgery arms are always having higher performing patients. And so maybe, we can formally show that because there won't be any twins between the two of them. That's just an example. Next slide. I think I'm almost at the end of time. So happy to take any questions. Always want to thank all the people who keep the lights on in the lab. And also thanks a lot for the SWOG group for the opportunity to present some of the lab's work. Happy to take any questions and thanks again.
So Sanjay, that was terrific. Can you hear me? I can't tell if I'm muted or not. Okay, that was terrific, and I feel like I've seen like the evolution of your talk over the years, and this is even better than the ones I've seen. So I know we're a little bit past time, but I think there probably are a bunch of questions that your talk has kind of brought up. If anyone wants to throw in a question in the chat, maybe we'll spend like 5 minutes on that before we move on to the projects, brief projects. But question off the top of my head was, what can we do, like clinical people who are, thinking about clinical trials, writing clinical trials, to facilitate future work, other than like, obviously like collecting images, but like, is there something else that could be written into trials or things like that would facilitate future work?
So I can only speak from the NRG side because we've kind of dealt with that, is actually adding into the trial just the secondary analysis part about doing quantitative imaging. And it can actually be very broad. We found out after talking to the NCI, it can be pretty broad, but it allows actually the ability for us to then anybody, not just our lab, but any lab, to be honest, to actually leverage that data in the future. It's very difficult to actually do it retroactively. It takes a huge process. So for example, like Dr. Schwartz in the imaging group here at SWOG, he has a UO1 on the lung map trial, and 3 years into that grant, they weren't able to get the data because it was so difficult to retroactively put that in. But if you actually prospectively put it in, then it's actually a possibility. The other thing that I think is really important is that like we need to figure out sort of what are the cool imaging questions, even though I'm a clinical radiation oncologist, obviously my clinical practice is not as in-depth in certain disease sites as trialists. And so like sort of figuring out the good clinical questions and where we think imaging can be helpful would be awesome. And then like, we could figure out prelim data and go from there.
That's awesome. So everyone think of good, Dr. Redamales asks, can we rescue RT DICOM from Triad?
Good question. Oh, this is one I could talk about for hours. I will tell you that yes, the answer is yes, and I think in the future that the NCI, at least in the conversations I've had with them, these data sets are going to become public very soon. The question always becomes, every cooperative group is different. So, for example, ECOG, very easy to get data. We've had ECOG data for our ECE algorithm, and it's not been a problem. SWOG, I think that there actually is a lot of opportunity here. And other groups, its levels of difficulty may be harder. But I think that there is an opportunity to rescue the ICOM data from Triad, as long as we have a set sort of, maybe that could be something that could be a goal of this group, to sort of push a process that is very formalized, that we can actually get through that. Because I think that it's different. People get data in different ways. It's actually not a set way of getting data from Triad.
All right, well, we'll add it to the list. That was great. Thank you again for presenting, Dr. Aneja. If anyone has any questions, I'm sure they'll reach out to you. That was terrific. Next slide, let's go on to the next part. Dr. Wagner is going to present something that he brought to the committee a couple months ago, and everyone was pretty psyched about it. And he's going to update us on subsequent work on this study. Take away, Dr. Wagner.
All right. Thank you for the opportunity to quickly present. So I just have a few slides, that's just to give a quick update, but this is a study that was actually just approved a couple of weeks ago by the executive committee. So it now has a number, it's S2208, and it's neoadjuvant nivolumab and paclitaxel for patients with local regional angiosarcoma, followed by definitive local therapy, which can be surgery or radiation. Next slide. So this trial was based off of results of another study, so the DART study, which was a sort of multi-cohort study run through the Early Therapeutics and Rare Cancers Committee of ipilimumab and nivolumab for many different types of rare cancers. We were able to add angiosarcoma as a cohort, and the results were actually quite encouraging. So you can see the waterfall plots here, where the response rate for at least the 16 patients with angiosarcoma who were enrolled was 25%. And it did seem like there was a skew towards patients responding with cutaneous tumors, and especially cutaneous tumors of the face or scalp. The next slide. So just a very quick and brief background on angiosarcoma. Most patients present with local regional disease. So angiosarcoma, of course, is a rare cancer. There's only about 400 cases diagnosed in the US per year. And it's a very aggressive cancer where long-term survival for really any patient, even those who present with localized disease, are very poor. But in spite of that, the vast majority do present with localized disease. And that's partly because so many of them are cutaneous tumors where lesions will come up and then eventually the diagnosis is made. Upfront therapy is somewhat controversial, but at least in the bigger sarcoma centers now generally requires multidisciplinary care, which includes very frequently chemotherapy, usually a taxane like paclitaxel would be the first chemotherapy that patients will get, and then surgery and radiation depending on the surgery that's done. There's currently a study run through Alliance that is asking the question of, for upfront therapy for patients with metastatic disease, does adding immunotherapy lead to a survival benefit? And that's a randomized study that's currently ongoing. So if anyone happens to have or know of patients with metastatic angiosarcoma, that's a wonderful opportunity. But to date, there have been very few studies describing the optimal upfront treatment, especially for patients with localized disease. And that's really the question that we're hoping to answer with this trial. Next slide. So this is the quick schematic of this study. So really any patient with localized angiosarcoma, and importantly, it can be resectable or unresectable, and patients are randomized to either, or will be randomized to either paclitaxel, which at many centers is considered a standard of care, versus paclitaxel with nivolumab, followed by definitive local therapy. Again, that's sort of up to the investigator's discretion, which can be surgery, radiation, or the combination of the two. And then in the adjuvant setting, patients who get just the paclitaxel will go under surveillance like they otherwise normally would, and the patients who are randomized to the nivolumab arm will complete 1 year total of nivolumab therapy. We are allowing crossover to hopefully improve enrollment, just because this is such a rare cancer and we want to make these immunotherapies available if possible. Next therapy. Okay, so we are also including correlative testing, and it's embedded in the protocol. The plan for correlative analysis is still not finalized because it's so preliminary at this point, but we're hoping to get pre-treatment, on treatment, and on progression samples, including FFPE and whole blood for various analysis, especially immune profiling. One important hypothesis that we have based on other data, which I didn't show here, is that patients with a high TMB are probably more likely to respond and to benefit from nivolumab. And of course, we'll look at TMB along with other factors that are relatively known to impact immune response. So this, like I said, was just approved by the executive committee. So it's still in preliminary stages, but is moving along and hopefully will be available at some point coming up. So I'm happy to take any questions.
That's great. Congrats.
Thank you. Yeah, very excited that this was approved.
So when should we expect you know, to start talking with our clinical trials groups and things like that to start accruing? How long?
Yeah, so as far as opening to accrual, it's still a little bit early because we have to first submit to CTEP, and that will just take a while. But you know, hopefully, maybe this is a guess, but maybe in a year or so. I mean, ideally even sooner.
Great. Well, thank you again. In the interest of time, we're just going to keep going on, but congrats again. That's wonderful work.
Sure, thank you.
Dr. Spears from the university that beat Nebraska last weekend is here to talk about his study, which I think we're all pretty excited about when he presented. So, Dr. Spears.
All right, thanks. Hopefully you guys can hear me. I apologize. There is a fire alarm going off in the background, and there's actually evacuation of the clinic right now, and there is smell of smoke. So I will try and be a little bit brief because I may have to leave shortly. Dr. Yu, can you guys hear me?
Yeah, do you want to go at the end? I mean, because I don't want you to actually die of smoke inhalation for the...
No, it's fine. Actually, there's a better chance I can get it done now than later, because I think I will have to leave after this. But thanks for that, the opportunity to kind of update you. We do have a few updates that are relevant to this trial. So this is we had proposed a phase 2 study of combining a CDK4/6 inhibitor with radiotherapy in women with locally advanced breast cancer. This is a study that Dr. Henry and Dr. Cobain are helping with, and you can go to the next slide. I will briefly touch on the clinical problem, the background of this, because I think it's been presented to this group before. We know that patients with ER positive, multi-node positive breast cancer do develop local regional recurrent disease at a relatively high rate, and that salvaging that can be a challenge. So preventing it is a more ideal strategy. You're also very well aware that CDK4/6 inhibitors are now standard of care, first-line therapies for women with metastatic ER-positive breast cancer. But really, and they're being evaluated in the adjuvant setting for women at high risk for distant metastatic recurrence. But the value or utility or safety of combining them with radiation in the adjuvant setting for that same high-risk population is not real clear at this point. Next slide. And so our group generated the preclinical data that suggested that combining the CDK4/6 inhibitor with radiation would make the radiation more effective. So regardless of the CDK4/6 inhibitor, palbociclib, ribociclib, or abemaciclib, there was significant radiation sensitivity conferred by the combination of those therapies in preclinical models, both in vitro and in animal studies. which led to then, next slide, this idea of combining them in patients with locally advanced but non-metastatic breast cancer who are at high risk for both local recurrence and distant metastatic progression. Next slide. And we know, as I mentioned at the very outset, that women with 4 or more lymph nodes positive at time of surgical resection are at a relatively high risk of local regional recurrence, with rates around 20 to 25%, even in modern series, with women with 4 or more nodes positive based on some NSABP and Swog trials and more recent trial data as well. So this is a patient population that we think local regional control still is not quite as good as we would like it to be, and might be an opportunity for us to combine a radiosensitizer like a CDK4/6 inhibitor with radiation in women with 4 or more lymph nodes positive. Next slide. And one of the challenges has been the lack of safety data in this patient population. So we don't really know whether this is safe to do, to combine these two. There are numbers of case reports, they're listed here in this table, of combining palbociclib or CDK4/6 inhibitor, most likely or most commonly palbociclib, in women with metastatic disease that were getting palliative radiation treatment. That generally says this is relatively well tolerated, but there's no real phase 1 data in the adjuvant setting to tell us that this is safe to do. And I'll come back to that in just a second. Next slide. So what we had originally proposed was a phase 2 trial with a safety run-in, in which women with 4 or more lymph node ER positive breast cancer or T3N1 disease could be enrolled in a randomized phase 2 trial in which they underwent their standard neo or adjuvant chemotherapy and definitive surgery as indicated, and they would be randomized then to radiation alone, as is the current standard of care, versus radiation with concurrent ribociclib at the adjuvant dose, 400 milligrams PO, and then continue on endocrine therapy, with the radiation being either standard fractionation or moderate hypofractionation allowed on this trial. And the primary endpoint was going to be invasive disease-free survival, with a number of secondary endpoints, including quality of life and correlative endpoints. This was a trial that received a lot of enthusiasm through the Swog group, through the other cooperative groups, but we got some feedback from the BOLD task force and the NCI steering committee that suggested that without safety data, they were a little reluctant to proceed directly to this randomized phase 2 with a safety run-in, and they'd be more comfortable with an actual phase 1B trial. So next slide. So there have been discussions ongoing over the last couple of months about this, and we had a recent discussion with Novartis, who was going to sponsor the trial, and it looks like we are going to go ahead and proceed with just the safety phase 1B trial, much smaller 30-patient trial, kind of dose escalation trial, starting at the target dose of 400 milligrams daily, looking at dose-limiting toxicities that occurred during radiation treatment and 4 weeks or 6 weeks following, 4 weeks following the completion of their radiation, so that we can generate this safety data that then can be the rationale for the larger phase 2 trial, which is still planned afterwards. Next slide. And so as of just earlier this week, we've had ongoing meetings with Novartis. The plan is to kind of move forward in parallel with the phase 1B, and then plan for the phase 2 to open as soon as we have that safety data. That is working its way through the IIT submission process with Novartis. The plan is to have 2 or 3 sites do the 30-patient phase 1 trial, with the goal of opening this trial in the spring of next year, generate that safety data, hopefully by the spring of 2023, and then also open the phase 2 right around that same time, with the safety data in hand that lets us know that we can safely combine these agents in women with non-metastatic breast cancer. And so that's our update. The trial is still on track, but we're going to have to start with the phase 1B before we do the larger phase 2, and we'll update the group as we get more information.
Well, kudos, Dr. Spears, to your perseverance. Obviously we look forward to, seeing the phase 1 data and seeing you on the stage at ASCO Plenary when the phase 2 or phase 3 comes out. I mean, I think it's super exciting, the combo, so kudos. I guess in the interest of time, we're just going to keep going. And thank you very much for bringing that concept back. So we've done angiosarcoma, we've done breast, and now we're going over to soft tissue extremity. And Dr. Jeremy Harris is going to talk about short versus long course radiation for resectable high-grade soft tissue sarcoma of the extremity. Dr. Harris.
Hey, thanks very much. I appreciate it. Can you hear me okay?
Yep.
Oh, great. Oh. So it's actually not that novel. It's been postulated for decades that kind of the optimal management, or maybe a preferred method of management of sarcoma, may be with short course. Now, the data are pretty sparse, but at least what exists seems to come around using a lower alpha beta ratio of 3 to 4 gray, and that's the case for both preoperative conventional fractionation as well as these high dose short courses such as SBRT. And now there are a number of studies that have used short course radiation in the operative setting. So these three have highlighted utilize an equivalent dose of 50 gray or higher with local failure rates of 0 to 8%. And that kind of comes at a cost of higher wound complication rate of at least 30%. And then in contrast, a lot of institutions have used 35 to 37.5 gray equivalent with local failure rates of 7 to 19%, but at least at a lower wound complication rate in general. There are also a number of ongoing single-arm studies that are either recently opened, recently closed, or sort of in the middle. And so I think this is a really great opportunity for a multi-institutional randomized study of short course versus long course for these resectable high-grade soft tissue sarcoma of the extremity. And so this would be the study schema for tumors that are small, less than 10 centimeters. We would propose using 25 gray and 5 fractions as the experimental arm. For those that are greater than 10 centimeters in size, that would be 30 gray and 5 fractions. And in both settings, the control arm would be the standard 50 gray, 25 fractions. Now, a lot of oncologists prefer the use of chemotherapy for the larger tumors, and so this would potentially allow for that, using doxorubicin ifosfamide-based chemotherapy and adjusting the dose in the experimental arm to 28 gray and 5 fractions. Eligibility would be adults with soft tissue sarcoma of the extremity that are high grade, excluding those with bone sarcoma, rhabdomyosarcoma, as well as those of retroperitoneal uterine origin, and any metastatic sites. This would be using 3 centimeter and 1.5 centimeter margins for CTV, allowing for either 3D or IMRT based technique, and also allowing for a boost in the setting of positive margin or gross disease. And one proposal would be sort of using that alpha beta ratio of 4 gray, allowing for a boost in the experimental arm of 8 gray. We would propose some 5 fraction constraints that have been developed for bone, joint, skin, and nerve. I'm not going to go through those in great detail. This is a more specific schema showing that surgery would occur 6 weeks after the end of radiation in the conventional and short course arms. For those receiving chemotherapy, surgery would be at week 14, and there's a slight modification of the chemotherapy regimen to allow for concurrent chemoradiation in the control arm. A primary endpoint would be non-inferior local failure at 2 years, and that would be benchmarked from RTOG 0630. This would require 204 patients for a power of 85% and a one-sided alpha of 5%, and allowing a non-inferiority margin of 10%. Secondary endpoints would be quality of life and treatment satisfaction based on questionnaires from PROMIS and FACET. We'd also look at wound complication as defined by NCIC, as well as CTCAE. We would look at pathologic response, survival outcomes, and cost. I'll skip this today, but this is the NCIC definition of wound complication. It's a number of outcomes. And really the impact, I think, would be standardization of short course across multiple institutions. Obviously, the primary endpoint is determining whether it's safe to cut treatment by 1 month, enabling oncologists to start surveillance earlier. I'll also note that in RTOG 0630, 6% of patients had progression prior to surgery. This would also potentially allow us to reduce toxicity for those smaller tumors that we would use a lower radiation dose for. And then I think this has huge implications with regards to health disparities and coordination of care, allowing us to more easily treat patients who are living in more rural areas. And of course, non-white patients tend to overrepresent those who have fewer resources for travel as well as treatment coordination. So that's pretty much it. Thank you.
Great, thanks, Dr. Harris. This is a, kind of a disease site that I guess what committee within SWOG? I think we talked about this when you presented. Would this be which there's no sarcoma specific, right? This would be like the rare disease.
That's right.
Great.
Can I ask a question?
So we did just start a sarcoma working group, but sorry, I heard there was a request for a question.
This is Sandy Constein. I wonder if I could ask a question. I mean, I do worry a little bit about toxicity to neurovascular bundle and so forth with the large fractions. But that aside, I mean, this is a study and I think it has a lot of merit. But could we be at all a little more nuanced in terms of our treatment, the recommendations we make for determining treatment volume, rather than just a 1.5 centimeter radial diameter on the axial images? Can't we have a little discussion about taking into account fascial planes? And because some of us like to consider that as we make our decisions in terms of the axial dimensions of our radiation fields for sarcomas. Worry more about axial, because sometimes you'll have a fascial plane right next to the tumor and you don't need to be at 1.5 centimeters, but other times you might want to be more than 1.5 centimeters axially due to the way the fascial planes run from the tumor. I just think it doesn't do the best job of discriminating areas of concern versus not. And we just have an arbitrary 1.5 centimeter axial volume.
Yeah, thanks for the comment. I appreciate that. And certainly it could be a little bit more nuanced. This was more to kind of spark ideas and discussion about that. But, I think, CTV management is certainly more nuanced, certainly like bone and joint spaces you'd be, cropping off of. And, I'm totally open to that.
And Michael Wagner did put in that there's a new sarcoma working group as well. Okay.
That's right. That's where this kind of came out of. This is, so we first presented this at the sarcoma working group.
Terrific. Well, it sounds like there's a fair amount of, as always, fair amount of interest. And if people want to get in touch with you, maybe just post your email in the chat. Thanks again. And we're back on time. We're going to move on to Dr. Kirchner, who's going to present an organ near and dear to my heart on prostate cancer.
Great. Thank you very much for the opportunity to present. So this is a proposal for a phase 2 randomized trial to study patients with oligoprogressive osseous metastatic castrate-resistant prostate cancer and treating them with immunoradiotherapy, a combination of a checkpoint inhibitor and SBRT. So next slide, please. So as we all know, immune checkpoint inhibitors are used for many diseases, but are not widely used for prostate cancer. There's a significant need because prostate cancer is the #2 cause of cancer deaths in men in the United States and a significant burden worldwide. Single agent immune checkpoint inhibitor trials have shown very limited efficacy in prostate cancer, and there are various reasons for this. But basically, there's ongoing pressure for multiple combination therapies to be investigated because we potentially could leverage the results of multiple agents fighting against the cancer. So here's just a smattering of some of those ongoing studies, some of which have some early results and some of which are not very promising at the moment. But there is one I want to highlight on the next slide. You can go to that. There was a study that was done with combination of radiation and ipilimumab, published a few years ago in Lancet Oncology, and they tried giving patients 8 gray of radiation to up to 5 bone lesions, and then combining it with high dose ipilimumab up to 4 cycles, and then longer than that if they're responding. And that was compared and randomized to 8 gray alone with a placebo in 800 patients. They did see a significant increase in progression-free survival, and that was radiographic progression-free survival at 6 months, boosting that up by about 12%, favoring the combination arm. They saw an increase in median overall survival, but it was very small, only 1 month, barely significant. There was a very recent long-term update of this, the final analysis, that showed that there is a long-term survival tail that is apparent, and therefore maybe there are some patients who are responding and having some immune reaction with some durability. So this kind of spurred us to say, you know, there's some potential response with a combination approach. Maybe we should continue looking into this. So if you can go to the next slide. The investigators also broke down their data with a post hoc analysis looking at patients who were the best responders and found that those who had favorable disease, which are defined by those characteristics of the labs there, alkaline phosphatase near normal and hemoglobin near normal, and no visceral mets, those patients, almost 300, had a significant median survival improvement of 7 months, which is quite dramatic in this very end stage population who had been heavily pretreated. When looking at just ipilimumab alone, a different study published that they had no real significant responses in survival there on the top right. So IPI alone didn't seem to do the job, but IPI plus 8 gray of radiation made a significant impact on some patients. And just as a reminder, on the bottom right, most of the currently approved agents for metastatic prostate cancer have about a median survival increase of 4 months on the landmark studies that got them approval. So we saw this data as promising and decided to suggest challenges to address, reducing the toxicity associated with ipilimumab and potentially increasing the responsiveness through a better design of the radiation treatment approach. So on the next slide, what we did in our laboratory was study some of the preclinical models that are available for prostate cancer. We know from multiple labs and publications that high doses of radiation can trigger a pathway called the STING pathway that ultimately generates type 1 interferon, and that's an immune stimulating approach. Various cancer models require various types of doses, and we studied 4 prostate cancer cell lines in humans, including human models, to find that there is a peak around 13 gray, somewhere between 10 to 16 gray is the range that triggers the highest doses of cytoplasmic DNA that can stimulate the STING pathway and production of type 1 interferon. Looking at this as well for dose and fractionation in the middle here, we saw that giving 2 doses of 13 gray seemed to be a higher stimulation than giving 1 dose or giving 8 gray, which is what was used in the trial that I just showed. So we think we can do better than the current approach that was used in that ipilimumab trial by a more clever design of the data here. We show on the right here that 13 gray times 2 is a similar dose to what's used in some of the SBRT related studies, including those for prostate bone mets, like on the STOMP trial, Aureole, and Saber Comet. So these are sort of compatible with our usual regimens that we can offer within the realm of reason. And you can go to the next line. Next slide. Yeah, this is a model we also took to the mouse. We have anti-PD-1 or anti-PD-L1 treatments independently, showing a combination approach. In this model, we did 10 gray times 2, and we saw significant increases in overall survival, as well as local responses of the tumor and actually a distant response to an unirradiated tumor in the same animal. So there was a significant improvement here, and we published this data a couple of years ago. You can go to the next slide. We feel like the model shows that there is definitely an immune response that's mediating this. If you look at the flow cytometry on these tumors, both the irradiated and unirradiated tumors in the same animal have an increase in CD8 T cells. And we can block that response of survival advantage by giving an anti-CD8 antibody. There on the right, you can see no difference in survival. So we feel like it is mediated by the immune system, and the combination approach is successful with PD-1 or PD-L1 treatment pretty similarly. The next slide. What we want to propose here is taking this back to the human group and do a randomized phase 2 trial where we can treat patients who have a need for treatment with oligoprogressive metastatic castrate-resistant bone mets, up to 5 lesions getting SBRT. What we would do is randomize them between 2 arms in which one was receiving a standard systemic therapy and the radiation as the need for the palliative treatment. And then the other arm would get the same approaches of systemic therapy and radiation, but adding in a checkpoint inhibitor for PD-1 or PD-L1. And that radiation dose would be the 13x2, which we feel is a reasonable one, given the location and scenario that the radiation oncologist would feel comfortable doing. Atezolizumab is our proposed approach. We've had some talks with Genentech about this. It's been a couple of years in the making, but they are sort of interested, and we'd be happy to consider them or other candidates for the checkpoint inhibitor. And then doing a radiographic endpoint was our main aim. So we have initial disease diagnosed on bone scan and then survey them again on bone scan about 12 weeks after their treatment. And if they are maintained without progression, we could continue the atezolizumab maintenance therapy. On the right here, we just show that the statistics would be 84 patients, 42 per arm, and we would have to use some sort of minimization approach to balance out the therapies that have been previously given, since this can be a pretty heterogeneous population of patients who've had multiple different lines of therapy, depending on how we design it. So we could have a flag for either next generation androgen deprivation or chemotherapy, to be balancing the 2 arms so that patients have had equal numbers of prior treatments in both arms. The eligibility would be up to 5 new lesions in a patient who is castrate resistant and have those normalish labs that showed significant improvement of response on that IPI trial. And then feasibility, of course, and no prior treatments that would interfere with the immune checkpoint therapy. You can go to the next slide, please. So progression-free survival radiographically is one of the main aims that is defined by the Prostate Cancer Clinical Trials Working Group. Bone scans being widely available are thought to be a reasonable approach. Even though we have access increasing to other agents like PSMA PETs, we feel like a bone scan is still mostly the universal way of detecting lesions when someone is widely metastatic or has oligoprogressive disease. So the definition of their progression would be having the development of 2 lesions, 2 new lesions, and then an additional 2 lesions found on a confirmatory scan at least 8 weeks later. And that's shown there in the figure that they recommend having a pre-treatment baseline and then a post-treatment new baseline there labeled week 9. And then that would account for any sort of flare that can happen during the treatment, having responded to a new line of therapy. And then that new baseline would then be analyzed for comparison to additional bone scans down the road. And if here at week 37, there's the 2+2 criteria has been fulfilled, that would be the flag for the new progression at the week 37. So these are kind of standardized approaches that are suggested by the PCW G3 group, something we could use in our study. Go to the next slide, please. We want to also look at multiple secondary aims, including overall survival, since these are end-stage patients potentially, local control of the irradiated lesion, the objective response of non-irradiated lesions to see if they improve on a bone scan, the PSA response rate, the time to rise of PSA, the time to developing new lesions, the safety of the combination treatment. And then, of course, we would love to get biomarkers depending on the funding available so that we could stratify between responders and non-responders and design the next level of study based on what we learned from this analyses. So peripheral blood could be collected for neutrophil and lymphocyte counts. We could look at inflammatory cytokines with a panel such as a Luminex multiplex assay. We could look at circulating tumor DNA to see if we could find changes in the absolute prevalence of the DNA, new mutational clones that might be responding to the pressure of an immune surveillance. We could also look at T-cell receptor profiling to see if there are clonotype expansions going on, and potentially the circulating tumor cells using commercial assays that have been shown to correlate with survival. Next line, please. And then after, sorry, you can go to the next slide. After that, we wanted to just emphasize the biostatistics is based on the single arm of the initial IPI trial that did radiation alone. So they had 18% progression-free survival at 6 months, which is quite low. And we were hoping to get at least, they did a 12% increase. We could probably achieve a 20% increase if we're bold, to try to show that our effect is potentially as good or better doing this enhanced approach with immune therapy and the radiation of a better dosing approach for immune stimulation. And so 84 would be our target. Next slide, please. We could consider alternative designs, and that's something of a discussion. I welcome everyone's opinions about how we could better improve this. The first option would be the one I described, which would be oligoprogressive disease, where patients are just developing new lesions on their current line of therapy and need to be radiated for a palliative reason. But we could consider an alternative there, number 2, that we would do it as a patient who has no additional standard of care treatment options, who've been heavily treated, sort of like the population that was in that IPI trial. Additional approaches could be considered to standardize systemic therapy, one being the potential for patients who are transferring from a non-metastatic castrate-resistant state into new metastatic castrate. So the people who develop just a few new lesions that are oligo, up to 5 lesions, potentially their providers might want to leave them on their current standard of care, like AbbVie or enzalutamide, and just allow radiation to ablate the lesions and then defer the next line of therapy as long as possible. So that's one concept we've been talking about. Another approach would be to standardize from being on a line for metastatic disease, such as patients who are on abiraterone and progress would then be switched to a standard therapy like enzalutamide plus this new trial. But both arms would receive the same standard of care agent that they could do. So that might satisfy concerns about the physician who wouldn't want to defer a standard of care that might be available. Next line, please. So in summary, we're proposing that a PD-1, PD-L1 approach would be a lower toxicity than a ipilimumab approach, and that preclinical data does support the efficacy of doing this combination treatment with a high dose of radiation to provide that immune stimulation. And I think progression-free survival radiographically at 6 months is feasible in these populations that tend to progress fairly rapidly. And biomarkers would be very interesting to have for future design of trials. So next slide, please. And I want to thank a lot of investigators who've been helping us in this project for many years. And thanks a lot to the Swog Hope Foundation for the Impact Award that spurred a lot of the development and the preclinical data for this concept. So thank you very much. I'd be glad to take any questions.
Thanks, Austin. That was great. I think this is a good time to emphasize the point that Dr. Kachnik made earlier in this whole meeting, that Radiation Oncology Support Committee has a potential trial spot for a small, phase 2 type study if it has support of the committee, and your project is exactly that. I mean, for folks who weren't on the GU call, Austin presented this and I thought was very well supported by the urologists, med-oncs. They were very enthused. They just didn't have a trial spot, and so I feel like this would be right up the alley for everybody. Any questions for Dr. Kirschner? All right, in the interest of time, thank you. Let's move on to the last presentation. Dr. Horowitz.
Thank you, Dr. Yu.
Yep.
All right. I'm happy to update the committee on our work moving forward, a neoadjuvant chemoimmunotherapy protocol for locally advanced anal cancer. As you all know, chemoradiation is the mainstay of curative treatment for anal cancer, and in general, we're quite successful with our treatments. However, patients with high-risk disease, tumors greater than 4 centimeters or node-positive disease, are at very high risk of failure with disease-free survival of 30 to 40% in the largest series. And so we're looking to try to improve outcomes for these patients. Next slide, please. So immunotherapy has shown a lot of promise for treatment of anal cancer, particularly in the setting of metastatic disease, and has recently been evaluated for the adjuvant setting on the EA2165 trial, which very recently completed accrual. And so we're waiting for reports of outcomes for that. But that gave adjuvant nivolumab after standard chemoradiotherapy. There are several other groups in Europe, particularly in France, Germany, and the UK, looking at the addition of immunotherapy to the definitive treatment of anal cancer, particularly the interaction trial, looking at neoadjuvant and concurrent enzabenlimab with DCF or docetaxel, cisplatin, and 5-FU for a prolonged period of time, 16 to 20 weeks prior to radiation. And they're stratifying the concurrent treatment with radiation based off of response. Patients who respond to this neoadjuvant chemoimmunotherapy are getting radiation with more immunotherapy, or if there's no response, they're getting standard chemoradiation. The German Radiance trial is giving concurrent as well as adjuvant durvalumab, and the Corinth study in the UK is going to be giving concurrent and adjuvant pembrolizumab. So looking at the landscape of recently completed as well as studies that will be opening shortly, we were thinking of trying to build on a protocol to try to reduce tumor burden, which might decrease toxicities related to large volume, high dose radiation to the pelvis, while not prolonging the package time of radiation significantly, which we know from the RTOG 9811 study of neoadjuvant chemotherapy might be associated with worse outcomes if given for a prolonged period of time before definitive treatment with radiation. Next slide, please. And so our hypothesis is that neoadjuvant and concurrent chemoimmunotherapy with radiation is safe and tolerable for patients with locally advanced high-risk anal squamous cell carcinoma. Next slide, please. And so this is a schema that we've been developing in discussions with Genentech for concurrent as well as neoadjuvant use of the TIGIT inhibitor tiragolumab and the PD-L1 inhibitor atezolizumab. So for patients with locally advanced, again, high-risk anal squamous cell carcinoma, they'll be randomized to a non-comparative study of atezolizumab and tiragolumab with carboplatin and paclitaxel, which is a regimen that Genentech has studied for patients with high-risk locally advanced non-small cell lung cancer and found to be a tolerable regimen versus the immunotherapy doublet alone. We want to try to keep our package time short to assess for response to this neoadjuvant therapy, while not, again, giving too long a time before the definitive radiotherapy component. Patients would then receive standard dose-painted IMRT, 54 gray, to the primary tumor, and again, dose painting to small nodes as well as at-risk nodal basins with mitomycin and 5-FU. And in discussions with the drug company, they're supportive of concurrent immunotherapy with the chemoradiation at that time as well. Our primary endpoint for this is going to be 3-month clinical complete response rate, which is, again, an early time point so that we can find our outcome relatively quickly with secondary endpoints of acute toxicity. 6-month complete response rate, which is really the gold standard, as well as 2-year outcomes for overall disease-free and colostomy-free survival. Biomarkers looking at ctDNA, which is shown to be prognostic, as well as serial biopsies prior to the start of chemoimmunotherapy and chemoradiation to look at the tumor immune microenvironment. Next slide, please. And so these are the inclusion and exclusion criteria, which are consistent with the recently completed and ongoing anal cancer studies. Next slide, please. And again, these are our primary endpoints as well as secondary and translational correlates. Next slide, please. And for statistics, we're looking at a complete response rate at 3 months. And so at that time point on the ACT2 showed a 52% clinical complete response rate. And we're assuming an 80% response rate, which corresponds to the best arm on the Accord 3 trial. And that gives us an N of 20 per arm. Now, given that this is not a well-studied regimen with concurrent chemoradiation, we want to have continuous toxicity monitoring as well as rigorous stopping criteria defined by Pocock boundary and a safety run-in to assess tolerability of this before we enroll broadly. Next slide, please. And so I think this is a novel approach to immune modulation, again, for locally advanced anal cancer, which is a strategic priority of the GI Steering Committee. We presented this to the Rectal Anal Task Force, and it was the concept was favorably reviewed, as well as evaluation of the ctDNA fits into the GI Steering Committee strategic priorities for anal rectal cancer. And the ultimate goal of this pilot study is really to identify a treatment regimen that we can evaluate in a larger phase 2 and 3 trial. So we've presented to this to the GI committee, who's supportive, but for a small trial, they're not sure that they're the right group to support this. So we're going to be presenting this to the early therapeutics group to try to get their support to move this forward. So with that, I'd like to take any questions or move along to the next part of the committee presentation.
So that's great. Thank you, Dr. Horowitz. And this is also another potentially perfect study for the radiation oncology slot, I think, although I'm a little biased. I think it would be great. So any questions at this point for Dr. Horowitz? Well, it's terrific. I think we're on time. Thanks again. So we've kind of gone around the body. So we're going to go around the body again and go through the disease liaison reports. Everyone's got like 1 or 2 minutes each, and we'll get done on time. Why don't we actually, if Corey's still on, or Eileen or somebody, because I don't think Reshma made it. She had a prior engagement, but anybody want to take the breast committee? Or I can do it. Next slide. Eileen, yes.
I mean, the meeting hasn't happened yet, but I know there's one Swog trial open. That's Reshma's trial. So I think you can just kind of click through it. Can you hear me? Okay. Yeah, so this is Reshma's trial, which is looking at aliparib or PARP inhibitor concurrent with RT versus RT alone for inflammatory breast cancer, which has been open for a couple of years now. Next slide. And it is a randomized study of 300 patients to either who have inflammatory breast cancer, who get standard care radiation plus minus olaparib. And then they have a number of secondary outcomes that they're planning to look at, but the main aim is local occurrence. Okay, oh yeah, and then this is the second trial, which is mine, which is through the Prevention Committee. I'll talk about that in the Encore, and then you all have already heard about Corey's proposed study. And then there's 2 studies that are being championed, the Taylor RT, which is occurring rapidly, and then BR007, which I think is just open. Oh, and then this is a slide looking at the MA39, which is a Taylor RT for women with low risk HER2 hormone receptor positive breast cancer who are Oncotype score of less than 18, so 17 or less, and they get randomized to regional nodal irradiation or no regional nodal irradiation. And the idea is de-escalation for low risk hormone receptor positive breast cancer. And I think they've increased amendments because there was some recruitment. So now they are allowing micromets for T3 disease. And if you have a sentinel lymph node alone, yeah, it's also micromets if you only have a sentinel lymph node alone. So it's an expansion of the eligibility criteria to improve enrollment for some patients which were not allowed previously. Right. Oh, and then the Deborah trial, which is just open through NRG, is a study in low risk hormone receptor positive node negative women who are between the age of 50 and 70. And it's looking at Oncotype score to randomize them to radiation plus endocrine therapy or no radiation and endocrine therapy. And this just opened over the summer. I think, oh yeah, and then the secondary analysis of the responder trial is planned. This is something I plan to do with Reshma, and so we're working on. Oh, hello?
I am actually here, so
oh, you are. Sorry. I was just doing it because you weren't here. Sorry.
No, this is great. This is great. But we have some preliminary results back from Bill ready, and so it's underway. But thank you so much, Eileen.
Sorry.
Yeah, awesome. Yeah, and looking forward to sending you stuff as soon as we have actually something more polished.
Great. That was awesome. Thank you, both of you. Tony is going to give us an update on CNS.
Hi, thank you. So the SWOG CNS committee is kind of new. It's a working group. Next slide, please. So I'm just going to briefly go over with the few minutes that I have on some of the ongoing trials that we have that are in collaboration with our colleagues at Alliance and NRG. This is the A071801 trial. This is a phase 3 trial randomizing patients with limited brain metastases who undergo a gross total resection that are randomized to single fraction radiosurgery or fractionated radiosurgery. And the primary endpoint is time to surgical bed recurrence at 1 year. This study was activated about 2 years ago, and it's accrued fairly well, about 136 accrual out of a 208 targeted accrual. Next slide, please. The next is NRG BN009. This is a phase 3 trial of salvage radiosurgery or salvage radiosurgery plus hippocampal avoidance whole brain radiotherapy for the first or second distant brain relapse after upfront radiosurgery. This is led by Dr. Chan, Michael Chan, and Dr. Vinay Gandhi. So for brain velocity, for those that aren't familiar, these are, it's defined, as I listed there, total number of new brain metastases since initial radiosurgery over the total time interval in years or or fraction of a year since initial SRS. Next slide, please. So patients have to have at least a KPS of 70 or more, no prior radiation therapy, whole brain radiotherapy, and cannot have a brain metastasis volume greater than, have to have brain metastasis volume less than 30 cubic centimeters. Patients who have a brain metastasis velocity of 4 or more at the first or second distant relapse are eligible for this trial. They are then randomized to either radiosurgery alone or radiosurgery as well as hippocampal avoidance whole brain radiotherapy. And the primary endpoint here is the time to neurological death. Next slide, please. This is an ongoing NRG BN007 trial. This is patients who have unmethylated, newly diagnosed glioblastomas who, after maximal safe resection, are randomized to your standard radiation and concurrent temozolomide arm, followed by adjuvant temozolomide, or they are then randomized to radiation therapy with concomitant ipi-nivo, followed by adjuvant ipi-nivo. Primary endpoint here is overall survival. And this is also accruing very well. Next slide, please. So there are two concepts I want to present, which is at the CNS working group on Friday. This is a phase 2 trial for newly diagnosed glioblastomas in patients who have unmethylated MGMT. This is a single-arm study for patients who have maximal safe surgery, followed by radiation therapy and atezolizumab and tocilizumab, which is a PD-1 inhibitor, as well as tocilizumab, which is an IL-6 inhibitor, followed by adjuvant atezo and toci. The primary endpoint here is overall survival at 1 year. And next slide, please. And this is another concept that's being developed by my colleague Manmeet Ahluwalia. This is a phase 1/2 study of TRC-102 in patients with newly diagnosed MGMT promoter methylation, glioblastoma. TRC is a basic excision repair inhibitor, and those who had MGMT methylation in the recurrent trial should improve overall survival in the salvage setting. So this is really for upfront newly diagnosed GBMs with MGMT promoter methylation, and I believe that is it.
Thanks, Tony. All right, let's keep rolling.
Okay, happy to present again. Next slide, please. So there are several trials that we're championing in the GI group that relate to radiation. So I can go through each of these very quickly. Next slide, please. So the NRG-GI 006 is a phase 3 randomized study of proton beam versus intensity modulated radiation in the treatment of esophageal cancer. This is Dr. Lin's study. Next slide, please. And so this is accruing pretty well with 72 out of 300 subjects accrued with a primary endpoint of overall survival as well as grade 3+ cardiopulmonary toxicity. Next slide, please. The EA2183 phase 3 study of consolidative radiation in patients with oligometastatic HER2-negative esophageal and gastric cancer. So for patients with 3 or fewer metastatic sites at time of diagnosis are getting treated with either FOLFOX or CAPOX and then randomized to either continued chemotherapy or continued chemotherapy after getting consolidative radiotherapy with SBRT. Next slide, please. With a primary endpoint here of overall survival and then secondary endpoints of safety and tolerability, as well as PFS. This study is temporarily closed to accrual, but we anticipate it's going to be opening up again. And so I think this is an important question to be addressed, and radiation is really the main question that's being asked here. So when it reopens, please try to open this at your institutions. Next slide, please. NRG-GI 003, phase 3 study looking at protons versus photons for hepatocellular carcinoma. This is the schema. 5 versus 15 fractions can be used for treatment. Next slide, please. With a primary endpoint of overall survival. Dr. Hong is the PI here, and it's accrued almost 60 out of 167 subjects. Next slide, please. And I had to take out the slide for EA2165, which was the locally advanced anal cancer trial, because that's completed accrual, and now we're waiting for the primary endpoint analysis. But the early stage anal cancer trial, the decrease is currently open, and this is looking at T1 or T2 node negative tumors, and patients are being randomized to standard dose chemoradiation versus de-intensified chemoradiation, depending on whether you're T1 or T2, going down to as low as 36 gray to the primary tumor with only 1 cycle of 5-FU. Next slide, please. The PI on this is Jennifer Dorth, and this is accruing very, very well, already up to 66 patients since it's opened, with the primary endpoint of disease-free survival and health-related quality of life. And there are a lot of secondary endpoints as well, looking at patterns of failure, sexual function, and testosterone. Next slide, please. And there's one trial in development that I want to highlight, the RATION trial, which is a rectal adaptive neoadjuvant therapy in preoperative ctDNA negative patients that's being developed by Stacy Cohen with the support of Hagen Kennecke and Lisa Kachnik. Next slide, please. So this is a phase 2 study looking at ctDNA directed neoadjuvant therapy. So this is patients with T3N0 or T1 to 3 node positive rectal cancer with a clear circumferential radial margin, and patients are going to be receiving standard 5.5-week chemoradiotherapy and then using ctDNA positivity or negativity to drive treatment decisions, whether they're going on to TME alone followed by observation, or FOLFOX or CAPOX followed by surgery and then observation. Patients who are persistently positive after chemoradiotherapy will be getting TNT with FOLFOX or CAPOX prior to surgery. And the idea is to try to de-intensify the treatment that patients get if they have negative ctDNA at the time of completion of chemoradiation. And so the protocol is going to recommend TME. If non-operative management is elected, patients will be followed with ctDNA. And if it turns positive in patients in observation, patients will get scanned, and then decisions regarding chemo will be per the provider. Next slide, please. That's it. Thank you.
Thanks, Dr. Horowitz. We're going to move really quickly in the interest of time. Next slide. There's 3 subcommittees within GU, prostate, bladder, kidney. Next slide. I'm just going to focus on the Swog studies. There's obviously a lot of studies that Swog is championing, and if you're interested in those, join the committee on Thursday or Friday. But the first one is Swog 1802, which is the randomized trial of standard systemic therapy versus standard systemic therapy plus definitive local therapy. Next slide. This is the schema. It's accruing okay, but we would like accrual to be a little faster. It's a difficult randomization given a lot of us are giving radiation for the low volume metastatic disease or low risk metastatic disease. But please consider this study at your tumor boards. Next slide. Overall survival is the primary objective. Next slide. And contact Dr. Chapin at MD Anderson. And there's like a video, there's all sorts of aids to help recruit this study. Next slide. Then the other study I'm going to talk about is SWOG 1806. This is the chemoradiation study, bladder preservation study, with or without atezo. Next slide. Accruing well, 220 out of 475. Again, please consider this study at your tumor boards when presented with a clinical stage T2 to T4 muscle invasive bladder cancer. Next slide. And primary endpoint is bladder intact event-free survival. Next slide. That's it. Dr. Park.
All right, thanks very much. I'll move this quickly as well. So I'll be talking about the lung committee trials. Again, just focusing on the SWOG studies, even though we have a lot of studies we're championing from other groups as well. So first, next slide, please. The SWOG Maverick trial is S1827, is a study of MRI surveillance plus minus PCI in both limited stage and extensive stage small cell lung cancer. So the benefit of this is that we're able to look at really all kind of small cell lung cancers. All the patients on both arms are getting MRI surveillance, but on one arm they are getting PCI, and one arm they're not. Overall, this opened in January 2020. Accrual was a little slow to start, but then eventually has really picked up now. Things up to 63 patients now as of October 12th. As of October 12th now, the study chair is Chad Rustoven, and the main things we want to get across here are that there's a recent amendment as well that has now allowed for up to 16 weeks after the last cycle of chemo instead of 8 weeks. So this should hopefully lower barriers to accrual. And then we also want to remind everyone that this allows hippocampal avoidance PCI as well as conventional PCI, and that we're also interested in allowing for dual trial enrollment as well. So these patients can be on the NRG CC003 trial, as well as the one more I'm not listing here, but there's other trials that this patients can co-enroll on as well. Next slide, please. NRG, the SWOG NRG S1914, SBRT plus minus atezo in stage 1 non-small cell lung cancer. So this is one of 3 trials overall, looking at the stage 1 cohort here, but this one specifically is looking at atezolizumab. This is actually non-randomized. It's randomized, but it's not involving placebos. So patients who get randomized to SBRT just get that alone. And then so this should lower barriers to accrual as well for patients who don't want to be on placebo arm. But patients get atezo, then SBRT, and then more atezo if they're randomized to the immunotherapy group. So far, this is accrued 51 as of September, and actually now up to 57 patients now. So it's also picking up accrual quite well in the last few months. All right, on the next slide, please. All right, SWOG S1933 is a single-arm study for borderline performance status patients with non-small cell lung cancer, stage 2 to 3. So this is looking at hypofrac radiation, 60 gray and 15 fractions with no chemotherapy. This is followed by consolidative atezolizumab. So again, single-arm study opened in June 2020. This is designed for 47 patients. So far, 8 have accrued. So we can definitely use more help in accruing to this study as well. Can we go to the next slide, please? All right, and the fourth one I want to talk about was just activated a couple weeks ago. This is SWOG's S1934, chemoradiation plus minus atezo before surgery in superior sulcus non-small cell lung cancers. So T3 to T4, N0 to N1 patients. These are the patients that we currently already use chemoradiation and then surgery, but the idea is would we have a benefit from adding immunotherapy to the neoadjuvant treatment. So far has not accrued as of 4 days after the trial opened, but we're hopeful that this will accrue soon after that. So that's all. Can you go to the next slide, please? Just in summary, we have for limited stage and extensive stage small cell, stage 1 non-small cell, stage 2 to 3 non-small cell, as well as these T3 to T4, N0 to N1 superior sulcus tumors. So lots of ongoing radiation trials in the lung group. So we'd love to have your support and happy to answer any questions at any point.
Thanks, Dr. Park. Lots of radiation and a TZO. All right, let's move on to Dr. Constein, I believe. Yes.
Okay, I'll still also be quite brief. So yeah, this is an ongoing study. So hopefully you've seen this before, and perhaps you've even put a patient on the study. This is a newly diagnosed advanced stage classical Hodgkin lymphoma. It's an intergroup study. Next slide. And this just shows you the chemo, newly diagnosed stage 3 and 4 patients, randomized to either nivolumab and ABD versus BV and ABD. And at the end of treatment, if they meet certain criteria, particularly Deauville 4 or 5 residual disease, but at least a 30% reduction in the maximum transverse diameter, then they do get radiation. The dose essentially is 30 gray, but we allow for a radiation boost to 36. Ideally, this is a simultaneous integrated boost using differential fractionation in order to accomplish that. And you can use 1.5 to 2 gray fraction sizes, so you should be able to figure out a way to do this. Next slide. This is just an example of a patient. We don't treat we don't treat the original disease volume. We treat what's residual, but still anatomically abnormal to 30 gray. And what gets the increased dose is the PET avid area, as you can see in the middle figure here. That we get that Deauville 4 area, we get the boost. The other somewhat larger anatomically abnormal area gets the somewhat lower dose. Next slide. And this is just gives you the radiation parameters, just to be sure that if you do have a patient on the study, you do follow the guidelines. And as you can see, it's 30 gray to the residual anatomic volume and 36 to the area that's PET avid. Next slide. So this is a study which is just in development, led by COG. It will be for early stage favorable and unfavorable patients. Again, it's with BV and PD1 and BACOP. This has gone through so many different iterations that it wouldn't surprise me if there might still be some change. And this is not open yet, so you won't have seen this yet, but just for you to be aware that this is in development, and you will be able to participate in it. Not everybody gets radiation, just those patients who are what we call slow early responders, and you'll get specific definitions of that. But suffice it to say that they will, if they have Deauville 4, if they are slow responders and they have Deauville 4 or 5 residual abnormality at the completion of therapy, then they get a somewhat increased dose. Next slide. And this is the schema of that study. Again, it will involve both AVD, ABVD, NEVO, BIACOP. It's gone through a lot of discussion, but if it opens, which I think it will, then there should be excellent accrual, and we should be able to answer some questions because the study does involve SWOG, Alliance, ECOG, COG. Next slide. This is a study that you should have at your institution. Again, it was COG led. Again, it involves Alliance, SWOG, and ECOG. It's for primary mediastinal B-cell lymphomas. And those patients who might get radiation are patients who are declared to receive R-CHOP at initiation of therapy, and then they'll get radiation regardless of end of therapy imaging. They possibly, well, that, I mean, essentially that's the study. The next slide. I think that should be it.
Great. Thanks, Dr. Constein. We got 2 minutes left. Dr. Wuthrick is going to talk about melanoma. Then Dr. Connolly is going to give us a quick Encore. And then we're going to have IROC Rhode Island talk in like 30 seconds. So take it away, Evan. Talk.
Yeah, I'll be pretty brief. Can you hear me all right?
Yep.
Okay. Yeah, so next slide, please. The focus of the Melanoma Committee obviously is in developing exactly how to use immunotherapy drugs the most. So that we have trials in desmoplastic melanoma, looking at TVAC with immunotherapy, and then looking in adjuvant versus neoadjuvant immunotherapy in stage 3 disease. Next slide. So the one study that I really want you to know about, though, that's very radiation therapy and radiation oncologists involved is a non-SWOG but cooperative group Merkel cell carcinoma trial led by ECOG, in which patients with stage 2 or 3 Merkel cell carcinoma after surgery are randomized to either adjuvant pembrolizumab or no immunotherapy. Most patients, of course, will have had radiation therapy after their surgery as well. So radiation oncologists are really important in accruing and recruiting to this study. Next slide. Overall, they're trying to enroll hundreds of patients into this study, so it's really important that we all participate. You know, other major initiative that we have is a pretty major secondary analysis of SWOG 1404, which was a randomized trial looking at older immunotherapy drugs like high-dose interferon and ipilimumab versus pembrolizumab in patients with high-risk stage 3 melanoma. The study accrued 1,378 patients, and whether patients got radiation therapy or not, if they had high-risk bulky disease or extracapsular extension, was up to the discretion of the treating team. And so we're going to look at outcomes of patients that had radiation therapy or did not, and look to see if radiation therapy in the modern era of immunotherapy had any impact on key outcomes like disease-free survival, local regional control, and overall survival. And I'll end there.
Terrific, thanks. Let's keep scrolling through. Thanks, Evan, for going so fast. Oh, wait, did you miss the end?
You just went through mine.
All right, go Eileen.
All right, so Encore committee update, just for everyone to know, this is a collection of 46 community-based practice that does outcomes-based research. The next slide is for reference, but it's the difference between NCTN trials and the Encore trials, and they really focus on outcomes like prevention, symptom control, quality of life, survivorship, and cancer care delivery. Next slide. There are 4 committees. There's really 5 committees, but they're in 4 meetings. There's only 2 studies currently ongoing or in development, which are have anything related to radiation and the cancer care delivery. There's an economic or cost effectiveness analysis in a study of concurrent chemoradiation with or without atezolizumab in bladder cancer. So that's like within the CCD committee. And then within prevention, I have my study looking at the use of IORT for DCIS, which DCIS, because it's pre-cancer, is considered prevention. And then there's no current concepts within symptom control or quality of life or the survivorship committee. These are interesting committees to know about because they do very interesting research. And like the next slide is just an example of the the priorities that are listed under the survivorship committee, and they do a lot of things that maybe radiation, looking at long-term outcomes of radiation toxicity would be within their wheelhouse. So if that's something you're interested in, I think it's worth checking these committees out. I've been going to the prevention meeting for a few years, and they're very open to radiation studies. There's just not many of us who go to these meetings. So that's it.
Terrific, thank you. And I agree with that. I mean, I think more radiation oncologists would be really great to have more representation there. And terrific, thanks. And so last but not least, for the hardy few that remain, I think we have do we have a report from IROC, Rhode Island? All right. Well, maybe next in the spring, we'll have them go first. How about that? And I just want to thank everybody for a fabulous fall meeting. If you are not getting the radiation oncology emails or meeting invites for the month, please shoot me an email. Dr. Kachnik, any last words?
I have to say this, maybe it's the virtual aspect, but it's been one of the most well-run, informative meetings that we've had in a while. So I just want to thank you for your leadership and our whole group, and those of you that have stayed on for the full 2 hours.
Yeah, I've been taking names. I've been looking at the attendee list. Thank you all for staying, and have a wonderful night. And no meeting in October because it's Astro. We'll see you in November.
Bye, everybody. Thank you.
Bye, everyone. Thank you.